Hi, I'm Dr. Sievers, professor of medicine, specialized in cardiology, vascular medicine, gender medicine, and also a board member of the German Society of Gender-Specific Medicine. Gender medicine is gaining more and more attention in Europe and especially in Germany. But the country where it all started is the USA, which has the most experience in gender medicine and also regarding setting up the gender medicine and gender health programs. And I have today Dr. Sharonne N, who is an expert in this field. Hi, Sharonne. It's great having you.
Yeah, it's great being here.
Sharonne, can you please introduce yourself to us?
Yeah, of course. So I am a non-invasive cardiologist. I am a professor of cardiovascular medicine at Mayo Clinic in Rochester, Minnesota, in the US. I founded our Women's Heart Clinic here in 1998, so it does go back a bit, and we continue to practice, and I currently lead our SCAD clinic. And then my administrative hat, I also do faculty development and academic advancement for the faculty at Mayo Clinic in cardiology.
Great, thank you so much. Sharonne, as you said, you founded the Women's Heart Clinic at Mayo in 1998, so a couple of years back. So we were one of the very first in the nation. And please tell us, what was your motivation and where's your strong interest for women's heart disease has been coming from?
And that's a great question, and I guess it has sort of evolved over the years. But when I was early in practice, that was a really exciting time in cardiology. We were learning about, actually preventing heart disease, right? We were doing more in diagnosing heart disease. And all of the studies that had been done to inform that new knowledge had excluded women, okay? And it was done for a variety of reasons, which we can talk about later. But what that then meant was, as I was trying to apply that new knowledge to my own patients, I realized when I was with my male patients, everything seemed to go as expected, meaning the tests had the appropriate or expected outcomes. They responded to the medications. And what I realized is for the women, it was less so. And increasingly, I realized that when I was sitting with my women patients compared to my men, I was much less confident because the evidence wasn't there. So part of the reason was very clinically driven. We needed more knowledge. I felt like if we had a clinic, a sort of a concentration of expertise and interest, we might be able to obtain those answers through research, or at least influence others to do that kind of research, and predominantly to start including women in clinical trials and medical research. And then also, importantly, once you have the results, analyzing it by sex. Your listeners may be surprised even that up until only a few years ago, you could publish a study on the hormonal effects, like the estrogen effects on, say, the vascular system, and do it on male rats. Right? Yeah. You didn't, and no one specified it. And I'm not sure, but I don't think it would have much implications for me or my female patients if a study was only done on men.
Yeah, that's so true. That's so true. So, well, you started the program very early. So let me ask you, what does it need to start a women's health program? Because we in Europe, or especially in Germany, are just starting to get these programs running. So what we need and what is important?
I think there will be a different answer for every group, location, and practice. But I think common to everything is probably leadership buy-in. I think it is being able to, whoever is the proactive person, in the case was me, is being able to make the case for why this is needed. Either our patients need it. Look, the outcomes for women are not as good as we'd like. Maybe we need to focus more. Maybe it's more market-based. We hear our women patients saying they're not getting what they need from their current care. But maybe it is if we don't put this expertise together, we won't be able to answer the future questions. So in my case, it was a relatively easy sell to the chair of my department, who felt that he saw the gap too. Sometimes it was selling my colleagues, who took the tack to say, hey, are you implying that I don't take care of women well? And that wasn't the implication, right? But I had to manage that. It was that maybe there are some things none of us are thinking about. We need to learn more. And I think that each system and setting up the clinic to meet the needs within that system. For instance, in the US, some are mainly preventive clinics. They're recognizing that women maybe don't have access to preventive cardiology, lipids, lifestyle. So that's the main focus. In our case, we were a subspecialty clinic within an academic medical center that already had subspecialty clinics, like special clinics for valve disease or cardiomyopathy or heart diseases of the muscle. And so in a sense, starting a new clinic to address the needs fit into a structure already. And I guess my advice to anybody thinking about this is if there is a structure in place, trying to figure out how to fit it in and meet the needs of both patients and the practice.
Yeah, exactly. Thank you for this. So how big is your program right now, today?
So we are, we see patients every day of the week. We have a group of, I think currently about 7 or 8 cardiologists who rotate through the clinic, and also a nurse practitioner who's in the clinic all the time. So our focus, we don't see every woman who comes into our program. Again, this is a subspecialty clinic. So our focus, we really carved out what are the things that disproportionately affect women. So that might be spontaneous coronary artery dissection or microvascular dysfunction. So that's the abnormalities of the very small vessels, which is more common in women. These things occur in men. We also, and then things that disproportionately or differently affect women. And so that might be, or premature coronary disease. So we really want to see that woman, because coronary artery disease or atherosclerosis, plaque buildup, is not common in premenopausal women. So that is an area. So part of it is carving out those things for which we feel that we really have expertise. So for instance, although I may see a woman who has new atrial fibrillation in my clinic, and that would be fine, that isn't necessarily the patients that we feel like is our sweet spot, right? It is more the coronary artery disease or some of those unique.
But do you have also an outpatient clinic, and do you get a lot of referrals from other cardiologists?
Yes. So for instance, just today, I actually saw a patient who'd been referred by a Mayo colleague. It was an interventional cardiologist who actually made the diagnosis of coronary vasospasm in a woman with some other factors. And so even within our practice, that patient probably is going to be better served long-term with our outpatient approach. We also, because of our research, we get referrals from outside for spontaneous coronary artery dissection. One of my colleagues, Dr. Rekha Mankat, her focus is on cardiorheumatology, because we know that in autoimmune conditions like lupus or rheumatoid arthritis increase the risk of coronary artery disease, and they're also much more common in women. And so we've carved out a niche. Now we see men in that clinic as well if they have an autoimmune condition, but it's mainly, so that actually falls under the Women's Heart Clinic.
Yeah. So on the Women's Heart programs are very important to provide this specific treatment. So on the one hand, it is very important to raise the awareness for the medical colleagues and the medical staff. But on the other hand, it's also very important to inform the general population. And this the information is still too little, and many women are still unaware of the cardiovascular risk factors and everything which is coming with this. So why is that, although women's heart and health programs have existed for such a long time in the US, that the women still are often unaware of all these specific women health topics?
Well, I think, you know, some of the very early studies on cardiovascular disease, Framingham, you know, which goes way back. The Framingham study, for those who might know, is a longitudinal study looking at the population and the cardiovascular risk in a small town in Massachusetts in the US. And we rely on that data for a lot of important things. But one of the things that one of the early publications was, okay, women with chest pain, they don't go on to have any bad problems. Men with chest pain go on to have heart attacks. That actually informed future research. If you think about that, now that was wrong, but if you think about that data, people who are planning future clinical trials are going to, with limited resources, say, I'm just going to enroll women. I mean, I'm just going to enroll men into this trial because women are going to do okay.
Yeah.
And that informed a lot of subsequent research. So part of it is we are still in 2023 playing catch up in knowledge. But some of those same research and clinical decisions informed how women believe. You know, they don't believe they're at risk. They see on the media this man, middle-aged man, walking down the street. He clutches his chest and has a heart attack, that Hollywood heart attack that doesn't even really happen to men. And they don't believe it. I will say the counter thing, at least in the US, is that the breast cancer community and the advocates were incredibly successful in raising awareness of women's risk. In the US, about 40,000 women die each year of breast cancer. About 250,000 die of cardiovascular disease.
Yeah.
Now, that doesn't mean that you know anything about those 40,000 women, but if we paid women, I'm saying globally, if women paid even half of the attention to heart health as they do to breast health, I think we would have moved farther.
Yeah, exactly. So what do you exactly do to inform the woman in your town or in your country?
Yeah, so I have been involved in a number of initiatives to advocate. So patient advocacy, I'm aligned with a national organization called Women Heart, which educates women to go out and educate other women. So it's a train the trainer program, and also does some advocacy for funding for research for policy changes. So I think having physicians and patients who can help make these changes and advocate is really important and raises awareness. I think patient stories, and for your audience, the media and our policymakers don't necessarily want to hear from me. The impact is the story of the woman who had chest pain that was not diagnosed. And it's the partnership between the healthcare clinician and the patients that can make a difference. I think the other is using our knowledge and the media to talk about things. So I give talks to ladies who lunch. I give talks at churches and synagogues and to the public. And if I get invited on a local or even national radio show or a podcast like this, is to try to talk and help people know how to take action. I virtually never will talk about that with at least talking about what are the signs and symptoms of a heart attack, because that's right. And there are still people, and particularly women, who do not know this. And so I think we as healthcare providers and clinicians can really play a role, particularly for our own patients, but even beyond that.
Yeah, that's true. So we have to talk about this and spread the information to get the awareness. That's so true. So you talked earlier about one of your main area of research and expertise, which is a spontaneous coronary artery dissection, which is uncommon and under recognized. And especially impacts younger women. And let me tell you a little story. I remember a patient who suffered an acute myocardial infarction and cardiogenic shortly after she gave birth to her son, which was a really tricky situation. And I was called in as an interventional cardiologist and did the heart cath on her. And she had a long, tortuous, spontaneous dissection of the anterior wall vessel, which we were fortunately able to treat with 2 stents. And the patient was in a really bad condition, and we were so happy that she survived. But it was very close. So an event like this, I will never forget, and not to think about how bad it would have been if we had lost her. So an unbelievable case, but very important to know that spontaneous coronary dissection can actually occur in this context, and that is your area of expertise. And in 2010, like 12 to 13 years ago, you founded a very large research program regarding this diagnosis and the treatment of spontaneous coronary artery dissection. Can you tell us about this program and the progresses and what we learned about that?
Well, I'll just say probably, I don't know your age, but I imagine you, when you went to cardiology school, probably learned the same thing I did, which was, gosh, it's so incredibly rare. We'll probably never see one or maybe 1 or 2 cases in our entire career. Yeah. Well, that was patently wrong. So for those who don't know, a regular or atherosclerotic type of heart attack occurs due to plaque buildup, a plaque rupture, a blood clot forming that blocks flow and causes a heart attack. That tends to be somebody who is older and maybe has some risk factors like smoking or diabetes or high cholesterol. A dissection of a coronary artery is a split between the layers of the artery, or a tear, meaning making a flap. Often these patients, 90+% are women. Most are premenopausal, so they're considerably younger. Some, a risk time is shortly after giving birth. And what I found, actually, it was through Women Heart, which I mentioned. I'm part of the education program. And in 2009, 2 women came up to me during a coffee break, and they said, "What's Mayo Clinic doing to research SCAD, or spontaneous coronary?" And I kind of popped up and I said, "Well, I run a women's heart clinic, and even a Mayo Clinic could not, because it's so rare." That's what I said. That's what I thought. That's what I had learned. And they said, "Well, you know, there's 70 women on this online community. We've all had SCAD. We've been connecting, and we think it's more common than our doctors think." And I had to think, 70, that sounds like a lot. And I went and did a literature search. The largest reported series at that time was 43 patients. So, but figuring out how to research this, still very uncommon, not rare, but very uncommon, when I only had their screen names for this online activity. So we developed a completely virtual registry where we got their angiograms, we reviewed, we confirmed the diagnosis, we sent out questionnaires, and now we've been following some of these individuals for a decade. And it has really, really changed some aspects. You as an interventional cardiologist know that, because we did not realize that when we went in with a stent, we were much less likely to be successful in a SCAD patient versus a regular heart attack patient, and in fact could cause harm. And so if we diagnose SCAD, we now know, if we can, we leave that artery alone. Now, obviously in your patient, you did not have that option, but there's a lot of things. And I think that we also know that many of these folks have very different risk factors. They often have abnormalities in other arteries. So I think of the research of SCAD being almost a test case, so to speak, of us ignoring women, because often those things that disproportionately affect women or only affect women, there have not been research dollars and interest in learning more about it. And I think if the SCAD story, which has been paradigm shifting in terms of how you and I care for these patients, there are other conditions like microvascular angina and other conditions that are out there that are ripe for better research for women.
Yeah, so that is, and there's also a pretty high recurrence rate, like 10 to 15%, right? That also has to be taken into account. So that is something that is not that common, but it occurs, and then you better know about it, and you also better know how to treat these lesions.
Well, and I think the other takeaway, not just for cardiologists and not just for patients, but also for emergency department staff and emergency technicians, ambulance drivers, is that this can occur in any age.
Yes.
And, you know, I have a patient who was skiing with her family, a college student. She was skiing with her family on spring break while up on the mountain, started having chest pain. She was 19 years old. And so the important takeaway is, if somebody's having symptoms of a heart attack, even if they are a teenager or a very young person, we need to take it seriously, and at the least check enzymes and do an ECG and care for them, because too often when a patient doesn't look like a heart attack patient, it's easy to dismiss them. That's
true. That is so true. Yeah. You know, another area of expertise of yours is a non-obstructive coronary artery disease, so-called microvascular disease or small vessel disease. So can you talk a little bit about these, how you diagnose it and treat those patients?
Yeah. So this goes back to some gender assumptions, sex and gender assumptions as well, because I remember I thought I had done my job. This is 20 years ago, when a woman came in and maybe she had an abnormal stress test and she was having chest pain, and I sent her for an angiogram. I sent her to somebody like you. You said her coronaries look great, no blockages. And I would say, great news, it's not your heart. We know now that at least in some of these individuals, it definitely was her heart, because yes, her large arteries were open, but the little tiny arterioles or arteries that dive into the heart muscle that we can't see on an angiogram were not functioning properly. They were either blocked or they would narrow down inappropriately. And so the outcome of not including women in research, the outcome of not taking, I guess, sometimes their concerns seriously enough to keep going, is they didn't get treated with preventive medications. They didn't get aspirin or statin therapy. And so 5 years later, they actually did have blockages in their main arteries. We now know that microvascular dysfunction is a significant cause of chest pain in men and women, but much more commonly in women. And until recently, there were really no medications that would impact the symptoms. And I think that's another indication of where we've kind of left women behind. There's a lot more interest now. The way we diagnose it is still challenging, as you probably know in the cath lab, is these are little arteries we can't see, so we have to do indirect measurements, either non-invasively or sometimes during an angiogram. So I think there's a lot of opportunity to get better at that. But if I have any of us, you know, when I talk to other physicians or even to patients, is we need to believe women, right? Yeah. When women come into us and say, I'm having this symptom, they are less likely, there's lots of data, they are less likely to be believed, or it's anxiety or it's menopause. And that is the story of SCAD. That's the story of microvascular dysfunction. And I think what we need to change in our brains is not defaulting to, oh, you're just getting older or some other excuses. Let's do the appropriate testing, because maybe, just maybe, we don't know as much about you as a 60-year-old woman as we do about a 60-year-old man when it comes to their heart.
Sure, that's true. That's true. So I just want to mention briefly, you have still another passion, which is diversity and inclusion, and you develop programs to improve equity and diversity in patients' care. And you founded, as I researched, the Center of Health, Equity and Community Engagement Research. So what's about this?
Yeah, well, I think this came out of realizing that when we talk about health equity, it's not equality. It doesn't mean treating everyone the same. It means treating each individual appropriately so their outcomes are the same, right? Because if we treated every heart attack patient, if we treated all women with SCAD the same way we treated men with regular heart attacks, there wouldn't be equal outcome. You and I both know that. The women would do worse. This is the same in the workforce. And I think as being a woman cardiologist, when I started, only 6% of cardiologists were women. And there were differences in career outcomes and opportunity. So the combination of trying to seek better equity for my patients and also for the workforce led me to lead diversity and inclusion efforts at Mayo Clinic for a decade. And we have over 70,000 employees. And so really thinking about how we can change systems, how we can educate our people to make sure that everyone has equal opportunity and outcomes, whether that means you're a female cardiologist or you're a female patient. And that sometimes really means us getting good data. We talk about data being really important for cardiology clinical trials. Data is really important when we're talking about diversity and inclusion. Are there barriers, maybe, or rules that have been set up that disproportionately disadvantage one group? So all of those things have, and I continue, even though I stepped out of the formal administrative role, the health equity, particularly for women, but also for African Americans who are at much greater cardiovascular risk in the US than white Americans, and looking to all of the factors, and there are many, for why that has. And if we think about how African Americans came to the US, it was usually under the conditions of slavery. And generations of Black individuals have had less opportunity, more racial bias, and that affects cardiovascular health. And there's a fair amount of data. So working with some colleagues and the community to try to address some of those inequities as well.
Yeah, so that is also a very important topic also for us in Germany, because we get more and more diverse and also mixed up with the cultures and everything. So we also have all these ethnicities we have to take care of, and also prevent cardiovascular disease and everything. So it is also very important for us. Sharonne, thank you so much for sharing your expertise and extensive knowledge and insights. I think that was a great interview, and I myself learned a lot, and I'm glad that you took the time to be with us. Thanks so much.
Well, it was a pleasure. As you can tell, I am passionate about this, as I know you are. So thank you for putting a platform for someone like me to talk about our passions and hope for a better future for gender medicine.
Thank you so much. Bye-bye.
Bye-bye.